Okay, we are here to talk about pediatric feeding. We recently took a continuing education course called The Pathways to Responsive Feeding by Bree Mullick, and we learned some new things that we really thought were important to share with some caregivers. I am Erica, this is Cassandra and Anne. We are speech language pathologists that work at Medical Support Services, and we're excited to share some information with you guys. Some of the talking points, so key objectives that we're going to be talking about today are typical picky eating, let's see, little technical difficulties. It's totally fine. There we go. So some of our talking points today, some objectives that we're going to be going over are typical picky eating versus disordered picky eating, pediatric feeding disorder, also known as PFD, neurodiverse feeding approaches, responsive feeding, and tongue tie. To start, we're going to do a little bit of a side-by-side between typical picky eating and then when that becomes disordered picky eating. So starting with typical picky eating, this typically peaks around the 2 to 5 years old time frame, and it's typical. A lot of kids go through this during this time as they get more independence and they start having more preferences. Ultimately, they consume a limited variety or a limited amount of foods. Tends to be less than 30 foods, rejection of different food flavors or textures, and they might start to have some strong preferences or likes and dislikes. Meal times can also be longer for these kiddos that have some picky eating, and they might need some special mealtime accommodations. So maybe the whole family is having grilled chicken and this family member is having a chicken nugget. Something as simple as that. We also wanted to note that something happens when kiddos are starting to get introduced to a new texture or a new solid. They typically will refuse that food up to 2 weeks. It's normal for that to happen. So it's good to know, if you offer one thing and they don't accept it, offer it again and see what happens next time and just kind of see where it goes. That 2-week period is kind of an exposure to the food and getting used to something new, which is typical, something we all go through. When it becomes the disordered picky eating, that's where we really see it persisting for longer than 2 years of feeding difficulties. And there's just more severity and significance there. So less than 15 foods consumed, very strong likes and dislikes. So maybe they won't even come into the kitchen if they smell something in there that they don't like. They won't come to the table if another family member is eating or drinking something that they don't like. And ultimately, it's a refusal to try all new foods. And when that occurs, we tend to see some growth and nutrition concerns that also come into play. And we'll see that there might be a feeding skill deficit occurring. So they only are consuming pureed foods like applesauce and pudding, and they never have the experience to really chew any foods because they're not accepting those, then that's where we kind of see maybe a deficit in their muscles in their mouth to chew and swallow food safely. And we really see if there's significant mealtime disruption. So there's a lot of stress and anxiety around mealtime for this kiddo and even for the whole family. So that's when we really see it becoming a disorder and far from the typical. When we think of disordered picky eating, that brings us to pediatric feeding disorder. So what I had said earlier, also known as PFD. So we might be referring to that throughout the presentation. An overall way to look at PFD is an impaired oral intake that is not age appropriate. And they're really associated with 4 large domains: medical, psychosocial, feeding skill, and nutrition. 1 in 23 kids are diagnosed with PFD. That really is a pretty high prevalence, and it seems to be going up. So we really wanted to talk about this diagnosis and how it affects some of our families. It is a multi-domain disorder. So as I said, these 4 different domains, they can co-occur with each other or they can occur in isolation when diagnosed with PFD. Starting with the medical domain, this is where we see those disorders. So maybe there's a GI disorder, some heart defects, hard times breathing. All of those things can impact our ability to eat and swallow safely. And sometimes when we see those diagnoses or disorders, we'll see reflux or excessive vomiting occurring. Going into the psychosocial domain, this is really everything that happens around mealtime and the relationship with the caregiver, the relationship with the setting of where you're eating. How is that environment? Is it very high anxiety and stressful for the child? That's really what we're looking at here, is the child feeling like they are forced to eat something or have to eat everything on their plate, and it's really tough for them to want to come to the table. Feeding skill is the area that we look at evaluating and treating as speech language pathologists. So we really look at the oral motor skills to chew, take a bite, and swallow safely. So when we see those difficulties, it can appear as choking, aspiration, so food going down the wrong pipe, the windpipe, and into your lungs instead of into your stomach, gagging, and excessive vomiting. We also need to think about, within the feeding skill domain, the sensory component. So I talked about, the motor movements of chewing and swallowing, but also think about everything that happens before we take a bite. So the way the food looks, the way it smells, the way it feels when we touch it, the way it feels in our mouth. Those are all things that we have to process and can be really hard for a kid with PFD. When we look at the nutrition domain, this is kind of what I talked about earlier with disordered picky eating. So when we see that selective feeding leading to maybe malnutrition, some sort of nutrition deficiency, or dehydration. Within this domain, we can see kids relying on other ways to get their nutrition. So maybe they have a G tube, an NG tube, or a J tube. Kiddos may also rely on things like Pediatric to supplement their meal times to help them grow. When we think of PFD, we also think of a population where PFD is pretty common. So when we think of individuals with autism, 62% of children with autism have pediatric feeding disorder. That is a pretty high amount. And as clinicians, we realize the importance of providing really individualized care to those individuals. Something also that we have found out is 82% of autistic individuals have one GI symptom. So whether that be constipation, abdominal pain, diarrhea, or reflux. So those are both two really high statistics that we found shocking, and just important for us to talk about how we can be neurodiverse caregivers and clinicians to these kiddos and how to support them. So we really need to shift our expectations. As caregivers and clinicians, of course, we want our kids to eat and grow and be happy and all those wonderful things, but we need to realize that autistic kids will eat differently, and that's okay. It's really hard to change our framework, but it's good to realize if they're meeting their growth and nutrition needs and they're happy and positive around mealtime, that's great. And it might look a little different, and that's okay. We also need to reinforce their autonomy. So they have a voice, they have a say. Autistic adults have reported a lot of trauma around mealtime or even past therapy experiences with feeding where they were either forced to eat something or had just some really negative experiences that have persisted into adulthood. So we really want to make sure we stop that in its tracks and help create positive experiences instead of traumatic ones. Therefore, it's important to create trust and build a relationship. Mealtime is really so much more than just consuming food. And the relationship with the caregiver, the other family members, is so important for that kiddo with PFD to feel comfortable and to feel like they have a voice when they come to the mealtime.
I think it's hard for families to understand that somebody else's relationship with food would be different, especially their children. Mm-hmm. And one person said it to me, maybe it was a podcast that I heard at one point. Eating that Cheerio or that unpreferred food for your child might be like someone saying, hey, why don't you go eat that live spider? To me, that immediately makes me go, like I have a very physical response where I do not want to be near, let alone see a live spider. Mm-hmm. So that, I feel like I've seen that look in some of the kids' faces that I work with, like, I'm not touching that. I don't even want to be near that thing. So that helps me feel something similar to what those kids might be feeling too.
Yeah, totally. And kind of going off of that, what we need to make sure we're focusing on is meeting them where they're at. Where are their current strengths at? What can we build off from there? What are they currently eating and what are they doing really well right now? Let's see if there's a way that we can build off of that. So really making sure we're not giving them something super scary and overwhelming at the beginning, and meeting them where they're at and building off of that. Going off of that, we'll kind of go into responsive feeding.
So we started to begin talking about these sort of ways of thinking, ways of acting when it comes to sitting down with the child who might have PFD. And so responsive feeding is what we want to focus on here for a couple minutes. And so I'm just going to sort of guide us through what responsive feeding is and those kind of principles that make up responsive feeding. So first things first is autonomy, right? What do 2 and 3-year-olds like to communicate best? No! I like to protest. I want to do it. So, right, that's our job then, to respect that no, as much as it might pull at you. So respecting a child's autonomy, making sure that they are intrinsically motivated to eat, not, you're going to get a reward after you finish your plate or after you eat your carrots, then you can have dessert. Those are all extrinsic motivators. So we really want the child to feel intrinsically motivated. I want to eat this because it makes me strong, or I want to eat this because it's my favorite, or I really love how mom makes these mashed potatoes. I really, want to choose to eat that. So it's all about kind of, it's two-sided, right? It's not you sit down, you eat this meal. It's very back and forth. Maybe it's talking about what the child wants to eat, when they want to eat it, how they want to eat it. Maybe they're starting to help you prepare the food. So just giving them a say, in what they're putting in their body. And also respecting when they're hungry and when they're full. And then moving on to our second principle of responsive feeding, competence. So we touched on this a little bit as well, but meeting kids at their level, right? If they're eating things like applesauce and puddings and yogurt, we are not going to put down, a big old salad in front of them that's got multiple textures, multiple flavors, and say, here, eat this. I expect 10 different foods that they really are cycling through, and these are the only things they're going to eat. And maybe it's buttered noodles, and you're really starting to get sick of buttered noodles, right? But the kid loves it. So maybe if you want to change it up a little bit, maybe trying a different sauce or a different seasoning. You're not going to jump right to lasagna that's got way different noodles, all these textures, all these flavors. So again, just meeting the kid where they're at. And then the third principle of responsive feeding is trust. So again, building that connectedness, sitting down at the table is more than just eating and finishing your plate and leaving, right? It's a time where we can build bonds and memories with our families, talk about our day. It's just using that mealtime as an opportunity to positively build our relationships, child-caregiver relationships, and our relationship with food, because we really want to start out early, teaching kids about and modeling about the positive relationship with food, so as to mitigate possible feeding disorders, anorexia, bulimia, that might occur later in life because they've kind of felt negative about eating ever since they were, 2 or 3 years old. So kind of some key points here. Again, child-led and motivated. We are using a positive language to reinforce positive associations with feeding. It's really our job as caregivers and clinicians to read and identify a child's cues, whether they're, pushing away or reaching for more, and respecting those cues. And again, behavior is communication, meaning, we're respecting those gestural cues. We can tell when they're done, and respecting when they're done. And also, we, as caregivers, clinicians, modeling the positive relationship with food we're always modeling, and kids are always seeing, you know, how we treat food, and
I think that's a good point. If mom and dad aren't eating their vegetables and modeling that kind of behavior, then it's hard to expect the children to eat the vegetables as well.
Mm-hmm.
So keeping that in mind too is what are you modeling for your children?
All right, so putting this all together, this responsive feeding, we'll kind of give you some examples and what it looks like. So remember, first off, we want to see the child is motivated, right? When we're looking for signs that they're motivated, maybe they're verbal and they're asking you, can I have a snack? Or can we sit down and eat? What's for dinner? Maybe they're not verbal, they're younger, one. They're reaching towards their high chair, reaching for the spoon. Maybe they're coming to the table and sitting down. They might even just give you eye contact, you know. And that's telling you, oh, yep, they want food. When the child's eating, again, respecting their fullness cues. You know, if you're feeding a child and you're presenting them with the spoon of puree and they turn their head, you know, that's clear communication. You know, I'm done. So respecting
in
that.
Situation, though, they might want to feed themselves too. A lot of kids, there's that autonomy. I will do it to myself because I'm in control.
I think that's a big piece too, right? Is when to sort of you're kind of giving up your
control.
Your control and giving it to the child. And it's as simple as, like you said, giving them the spoon. And then that makes a world of difference because they're in control, right? Tantrums. Tantrums are another clear communication that's a child's done. You know, again, maybe we don't want them to be. A lot of the time, believe it or not, the goal is not to eat. Sometimes, I mean, that's our overarching goal, right? That's our long-term goal. But we have to take many baby steps to get there.
Sometimes you have to break it down.
Right? So first, it's important to establish associating eating or mealtime with that positive feeling. This is a good experience. This makes me feel good. I love sitting down at the table with my family. And then, you know, we're creating a time where bonding occurs, and the meal is just the facilitator of that positive experience. And then we might move on to touching and playing and tasting. But I'm not at all going to come to a meal time with any of these expectations in place and pressure the child. I'm going to follow their lead and then expand on where they're currently demonstrating their trust, right? Oh, okay, I put mashed potatoes in front of them. They're poking at it, right? Okay, now I'm going to poke at them too. And then I'm going to poke at them with a fork. Maybe I'll put my whole hand in the potatoes and then see if they imitate that action and just kind of build from there.
I think another part to think about too is that mealtime doesn't necessarily start when you're sitting at the table. It actually starts when you're grocery shopping for the food, or you're cooking the food or cutting things up. And children of all ages are more likely to eat something that they've prepared, or they've had a little bit involvement in. So something to keep in mind too.
Yeah, the meals are so much more than the meals. And I feel like with Thanksgiving coming up in all of our cultures, meals are a way to get together and a time to connect, and trying to realize that that could be sometimes more important, like Cassandra said, than the consumption of the food. That experience needs to be positive for the progress to build.
I would also say that holidays are not necessarily a time to try new skills or to push new skills, because they're probably more heightened emotional burden on that child anyways, out of their routine and new people and new emotions. So maybe not the best time to try new things. All right, so we're going to shift gears a little bit to kind of a hot topic about tongue ties. There's a term with tethered oral tissues is kind of the overall reaching term, and that includes tongue tie, lip tie, and cheek tie. So you're going to see, if you do like a Google search or talk to anybody, there's so many different opinions out there, from doctors to different therapists to different parents. Out there on Google, there's lots of different experiences. But I was hoping to just kind of give some general information to clear things up, or at least let you know what the questions are to ask. So these are some pictures of a tongue tie. Just, it can look different ways. If we look in the mirror, we all have a tissue there, and it varies from person to person. And these are pictures of a lip tie. You can see that upper frenulum there. And these are pictures of a cheek tie or a buccal tie. Beware of Google Doctor and social media opinions. Every child has these tissues, but every child is different in a wide variety of variation. And there's a lot of biases out there for people that have different opinions. There are some families that make appointments for their baby's tongue to be clipped before they're even born. That's how kind of aggressive some families are out there. And there's many of these surgical procedures that don't need to happen. In my experience, I've seen children admitted to the hospital who have refused to eat and with dehydration because they've had such a negative experience with the procedures with tongue clipping. I've also seen kids in an outpatient setting who are starting to be averse because they've had their tongue clipped and they're doing some post-surgical massaging and cares. And often the challenge of the newborn infant is one of practice. Eating is a new skill, and it takes time to get better at it. So just a little bit about what does the research say. First of all, there is really low, insufficient evidence that releasing tongue ties improves feeding. There's a lot of studies out there, and a lot of them have different weaknesses in their studies. But generally, there's no evidence that shows if you clip a child's tongue, they will eat better. There's also no evidence to support lip tie or cheek tie releases. The presence of a lip tie does not impact breastfeeding at all. So that has been proven in research as well. Less than 50% of infants and moms that have tongue ties report feeding issues. So maybe there's a tongue tie that's there. Only 50% of the moms and babies experience issues with feeding from that tongue tie. So just because you have a tongue tie does not mean that functionally it's going to impact your feeding. The research also shows that a multidisciplinary approach to tongue tie intervention is what reduces surgical intervention and improves breastfeeding overall. So many people report positive changes after a tongue tie release, but there might be other things that are going on at the same time, including growth and maturation. Maybe they're getting some chiropractic services or PT for torticollis or other things that are impacting that child's ability to coordinate feeding. And the tongue tie release may be just an incidental thing that happened, but it's not actually what is improving the child's feeding. I've also seen children who have gone through such releases and their feeding doesn't change because really the problem wasn't the tongue tie or the tissues that are in their mouth. It might be their coordination of their feeding skills. So there was a paper that was published in 2020 by the American Academy of Otolaryngology, head and neck surgery. And they basically they gathered a panel of all the experts, ENT experts, and they said, okay, what do we agree on and what do we not agree on? So the consensus studies, ENTs agreed that tongue tie is overdiagnosed and overcorrected. Surgery to correct a cheek tie should not be done. These are things that doctors agree on out there. Breastfeeding and maternal pain can improve without surgical intervention. So you don't have to have a tongue tie release for those things to get better. And there's no evidence that supports the post-care exercises. So a lot of times a dentist or an ENT will identify that there is a tissue there that needs to be released because the mom is reporting breastfeeding pain or the baby's having poor weight gain. And then, so they go ahead and they do those procedures, and then they recommend that there's some massaging or breaking the scar tissue so it doesn't heal inappropriately, and that causes a lot of significant stress for those infants. And then they don't want anything near their mouths, and that's how some kids can go down the road of dehydration. So ultimately, we all have these tissues. But it's about function. I don't really care what your mouth looks like, but if you can functionally suck, swallow, breathe, and drink from a bottle or from breastfeeding, and you're gaining weight well, then that's really what it's about. And oftentimes these ties are just normal variations that are being identified as problematic and being clipped when they didn't need to be. Tethered oral tissues are blamed for a lot of feeding problems, and they're cut, but the problems continue. So consider that feeding a newborn is a learned skill. Before they're born, all they have to do is suck and swallow in utero. And after they're born, they have to suck, swallow, breathe, and it takes some time for that skill to improve and mature. And it's new with every child, that mom-baby coordination takes some time to practice the skill. So oftentimes what the family and the child needs is just education and proper latch, possible changes in flow of the nipple, possible change in the bottle shape to help that child have a good latch and a good suck, swallow, breathe to be coordinated. Time and practice of this new skill often yields improved skill, less pain, and more efficient feeding. Another claim out there is that tongue tie can impact speech or sleep or need for orthodontic help later on in life. But again, there is no evidence that tongue ties or tongue ties specifically influence any of those things. In fact, sometimes releasing the lingual frenulum might actually cause more sleep issues. Right, but there are times when a tongue tie may be beneficial. These are done, a tongue tie release or a lip release would be done by a dentist or an ENT. They would either do a laser procedure or a cold scissors procedure. There is some question as to whether clipping with the scissors is better because the laser involves heat and you can have more damage to the tissue, the surrounding tissue with that heat. Some people say that there's better healing with a scissors cut versus a laser cut, so there's things to keep in mind and discuss with your provider. And then again, there's no evidence for those stretching protocol post-surgical recovery. It may cause oral aversion, and the stretching and reopening of the wound may actually cause worsening scarring, which would decrease the range of motion of those tissues. So those are other things to consider. And if you think about it, an infant who is eating at that age every 2 to 3 hours is functionally moving their tongue in the directions that we need them to stretch. So they're actually doing their own functional exercises every time they eat.
Yeah, the eating is the exercise.
The eating is the exercise.
Functional.
Yeah. So key points for tethered oral tissues, tongue ties. Get a functional evaluation with a speech pathologist prior to surgical intervention. Determine if there is a functional need to have surgical intervention for, or if there's something that can be done at bedside, so change in position, change in bottle to avoid a surgical procedure that is a negative experience for you and your child. Avoid oral motor exercises that are outside of function. Anything outside of function, passively moving structures and tissues is not helpful to achieve your functional outcomes of improved eating. And consider the secondary impact of the heat of laser surgery and discuss that with your ENT or dental provider. So we've covered a lot, and I'm wondering if there's any questions.
Anyone on the live stream?
If there are further questions, if we sparked something or you didn't, you have more questions about any of the topics that we've talked about, please reach out and we would love to talk more. We do free 15-minute screenings over the phone or in person. If you had some questions specifically about your child, we'd be willing to answer those for you.
We've got lots of resources too. So if you ever need a resource on anything we've discussed, we definitely have some of those.
Yeah.
Stick around for a bit.
Let it ruminate. Okay.